So really, we started thinking about when we would offer local therapy in terms of sequencing. Could we offer, and there's one other, and the first one I should mention here before these three is upfront. If you are diagnosed with metastatic disease, but you have only one side of disease in the brain or in the adrenal, and that's taken care of by surgery or SRS or radiation, why can't we be aggressive with local therapy for the remaining disease you have in your chest? So that's treatment up front at the time of diagnosis to go along with systemic therapy. There's not as much data about that, but I'll maybe provide some highlights later on in the question and answer part about how that can actually avoid some of the acquired resistance that we see in our patients. But the areas that I wanted to focus on are consolidation and oligoprogression that Dr. Singhi had pointed out before. Consolidation being patients receive X amount of systemic therapy. We want to make sure that the disease is still controlled, and then that's the time to offer local therapy. Versus oligoprogression, where patients are receiving systemic therapy for some definite period of time. They may develop acquired resistance, and then we treat whatever areas are progressing, allowing these patients to remain on the same systemic therapy in order to optimize their long-term outcomes. So unfortunately, or you could take it two ways. Most of the studies that we've done that have looked at use of local therapy in advanced non-small cell lung cancer patients have been done at consolidation and have been done in patients that do not have targetable mutations. So these are some of the major studies that were conducted over the last 10, 12 years that really started showing us that in a randomized small series of patients, those that received local therapy may actually have an improvement in progression-free survival and, in fact, overall survival. And the Gomez study, which is the topmost study that has a red arrow, did include a percentage of patients with EGFR mutated and ALK mutated tumors. And so we did have a signal that local therapy is good, it's safe, and it may improve PFS and overall survival. So all of those small studies culminated in a larger study. But this larger study, just as a reminder, called LU002, did not have patients with target mutations. We started off by focusing on patients that received immunotherapy-based systemic therapy. They got 4 cycles, as long as they had controlled disease and few sites of remaining disease. They were randomized to either radiation and surgery, followed by maintenance systemic therapy, or just maintenance systemic therapy. And this is the largest study ever in the oligometastatic non-small cell lung cancer space to ask the straightforward question: do patients with localized limited metastatic disease benefit from local therapy? And unfortunately, despite the increasing signals in the previous studies, there was no significant PFS benefit, no significant OS benefit. But there were lessons learned. And the lessons learned were as follows. It looked like the radiation and surgery did its job. There was fewer sites of disease that were treated with radiation or removed by surgery that failed locally. So that was really good. There was actually a trend towards a delay in the development of additional metastatic disease. So that was good as well. So if the local therapy was doing what it was meant to do, control disease where it was aimed, and delay the development of metastatic disease, why didn't that translate into a benefit in progression-free survival or overall survival? And what we've really come to learn, and this is going to be actually data that we're going to submit to a journal soon, was that toxicity played a role in this patient setting, in patients that were receiving immunotherapy-based systemic therapy followed by local therapy, that there was significant enough toxicity that it may have diluted the ability of us to translate a local control benefit and a delay in metastatic disease to a survival benefit. But look, we're learning our lessons, and subsequent iterations of these studies, we anticipate tightening up the treatment fields, reducing the toxicity, and potentially being able to show that local treatment in the form of radiation and or surgery is beneficial in a larger, type of study. But, so what were the limitations of these studies, a few of which that included targeted therapy? It's really that we're not doing enough to identify the patients through biomarker selection that are going to ultimately benefit from the treatment. And this schematic on the right is just an example. If you on the graph, if you start from the leftmost part of these curves, we treat patients with metastatic disease with local treatment in the hopes of improving their survival. But we, as radiation oncologists or even medical oncologists, have a difficult time predicting what direction your disease is going to go after we offer the local therapy. So at Memorial Sloan Kettering and other institutions, I think we're making a very strong effort to develop the biomarkers which are optimally going to select the patients that are going to truly benefit from local therapy. And the other thing I pointed out is we have to reduce toxicity. And those are really the key takeaways of that class of trials.